Hi, everyone. Welcome again to an interview with this time Sam Balkhy. Husam Balkhy, I'm so sorry. He is a cardiovascular surgeon, a specialist in robotics. Everyone actually knows you. And he works at University of Chicago. And we're still at Cincinnati at the ECS Club meeting 2025. So let's start with, so you've been a robotic surgeon for a long time, right?
Yes.
You have trained a lot of people, a lot of teams. I think actually in Colombia, you trained one of the teams.
Yes, indeed. Yes, indeed.
So I would love to have like a guide about how you start a training and how you train others.
Thank you. Well, first of all, thank you for inviting me for this nice interview on CTSNet. We really value the product that comes out of CTSNet, and I think the team with Joel Dunning and the team in Chicago have been very, very active this year and produced amazing content. So thank you for your efforts on that as well. So in terms of robotic training, so I've been doing robotic surgery probably since late 2006, 2007. So we're coming up on 20 years now. And there's been many, many teams that came to see us, whether it was where I first started doing robotics in Milwaukee, Wisconsin, or more recently at the University of Chicago Medicine, where I've been now for the last 12 and a half years. It's been interesting to see what it takes to produce a successful robotic surgeon and or team. And I think we went about it a little bit wrong in the early days, where people would go train, observe a case and do some very basic training and then go back home and try to reproduce what they had seen and not be successful, unfortunately. I think we've learned a lot from that. And it seems to me that spending some dedicated time doing robotic advanced training is perhaps a necessity. Now, I will temper that with the notion that simulation has become much more sophisticated now than it ever was. And in the decade or so since robotics has kind of left cardiac surgery and now it's back, there have been some wonderful advances in simulation, simulating not just the technical aspects of the operation of the robotic system and how to move the arms and things, but also the technical aspects of each operation. And so right now, with the resurgence of robotics in cardiac surgery, the companies are making real live high fidelity simulators that can duplicate a real procedure. And so the need to train on a patient, which was always kind of
Scary
to say the least, is going to hopefully become obsolete, where you can get in 50, 100 repetitions of a certain part of a procedure early, before you even touch your first patient. So the learning curve then changes from having been post your first case to all having been pre your first case. So instead of learning after your first case, you're learning way before your first case.
So how many cases in simulation you think you require? Of course, it depends if it's a coronary case and if it's just a Lima to LED or if it's I don't know, 3 vessels and a valvular. What would you say?
Well, it depends on what it is that we're talking about. So if we're talking about, say, for example, internal thoracic artery harvesting, how many cases do you need to be proficient? I would think once you go through the basic training of the robotic instrumentation and how to move and how to to manipulate the instruments from the console, you would probably need anywhere from 30 to 50, I think, IMA takedowns in simulation. And then and be able to do the first one. I think if we're talking about totally endoscopic anastomosis, it will take even more than that. You do that either with a beating heart model or an arrested heart model. Maybe you start with an arrested and you advance to a beating heart. In terms of the mitral valve, for example, repair, type procedures. I think a lot of that depends on your understanding of the mitral valve, because in the end, you're not learning how to repair the mitral valve. You're really merely learning how to apply robotic principles to it. And so the simulation is really necessary to perfect the motion and the movement of the robotic instruments and your relationship to the telesurgical aspects of the situation.
Also, I'm always intrigued about the depth of the sutures or something. So how do you actually manage to get that, like the depth and the tactile feeling?
Yep. It's something we call visual haptics, where your eyes start to understand what happens to the tissues when you manipulate them with the robotic instruments. Mm-hmm. And so I can feel how soft a coronary artery is, or how calcific a posterior annulus of the mitral valve is. Mm-hmm. With repetitions, you start to understand those motions. Now, there are some forays into forced feedback where you can get some feeling, but as Dr. Chitwood said today, it's not going to be refined for a long, long time. Especially in the cardiac surgery space. That's one of the good reasons to do a lot of repetitions, is to develop that visual haptic feedback loop, such that you're not kind of waiting to understand where your instrument is. You have that situational awareness inside the chest that you understand, and that's part of this super fellowship or advanced training that I speak of, where once you've done your reps on the simulator, now you enter into the clinical arena and you can be part of an established team for a period of time to understand the communication.
Planning.
Well, the planning of the surgery and all that, but intraoperatively, there are things that you don't get from the simulators, and they need to be kind of experienced. You have to experience them and be there.
Field.
Day after day after day, communication with the team. For example, in our operating room, we use Bluetooth headsets, and we have a very tight communication style between the surgeon at the console, the tableside assistant, the perfusionist, the anesthesiologist, all that situational awareness of where the instruments are. Those are the things that you pick up from attaching yourself to a unit and being there for a dedicated period of time. I don't think casually doing a robotic operation once every 2 weeks is a good way to get mastery of the techniques, because it's not how our brains work. We need to be repetitively, and we need to continue to do it to be able to get better and better. There's a paper written by Mike Halkos from Emory that differentiated between getting through the learning curve, which is the old-fashioned way of saying, kind of practicing on the patients to get better, versus mastery. And getting through a learning curve, depending on where you started on the learning curve, could be 50, 100, 200 cases. But mastery, in his paper, which is very interesting, was at 500 cases. And that's the time where you really are in a steady state.
Every day.
And you're not improving, you're not iterating, you're not learning anymore. You're in a steady state of a very, very successful and smooth operation.
Okay. So you have, of course, I imagine, you have a fellow right now in
We just
Robotics.
graduated a junior clinical associate, Dr. El Jamal, who literally this week just started his position at the Mayo Clinic for a assistant professor on the faculty there, and he spent a whole year. He's totally dedicated to robotics, and specifically robotic coronary surgery. I think he's capable of doing all different types, but he's very dedicated to robotic coronaries, and he actually benefited a lot from simulation, and he was able to exercise his hand-eye coordination on the robotic instruments very effectively by doing endoscopic anastomosis. He presented a paper at the recent ISMICS meeting that we had in Istanbul a couple months ago, and showed some video of his first anastomosis on the simulator and then his 50th. And then he showed one that he was doing intraoperatively on an obtuse marginal branch on the back of the heart, which is, not the easiest place to be endoscopically. And he progressed very, very quickly in the clinical setting because of the simulation that he did.
So you actually gave me the space.
Another segue.
To go to the next question or topic that I want to actually treat with you. So you are a coronary and valvular robotics surgeon.
Yes.
You do everything, mitral, aortic, and coronary. And usually it's like one or the other. How that happened?
Well, that's a good question. I think it's the new wave. It's what should be, because the robot, in my mind and in many others, is merely an instrument. And we are heart surgeons. We trained how to fix valves and how to replace them and how to do coronary bypass, not to mention other things like adult congenital, or I don't do pediatrics, arrhythmias, tumors, myxomas, PFEs. And if you are facile with the robot, then you should be able to do all of it. And I think it feeds into each other. So if you're doing multi-spectrum robotic surgery, it means that you're getting more reps. And not only that, but your team is getting more reps. So the way that happened, basically in the early beginnings of my career in robotics, is that I was doing all of my valvular and non-coronary surgeries through a small incision from the right side, using the Hugo Vanneman approach with the endoballoon and port access, what we call mitral aortic valve. My coronaries, on the other hand, I was not comfortable with multi-vessel non-sternotomy coronary surgery. And so I sought the robot to enable me to move to the next level of coronary surgery, to be able to do multi-vessel endoscopic and sternal sparing coronaries. Eventually, after I started that, it became very clear that for the team to be successful, they needed to be operating, and I needed to be operating with the robot on everything. And so gradually, over a period of time, we started with the coronaries, and then we started incorporating other things like the mitral valve and arrhythmia surgery, and then eventually aortic valve. I think we did our first one in 2010. And so eventually, and now for the last 7, 8 years, all my practices, I don't do a sternotomy. It's all robotic.
So I have a question about that. So you haven't done an sternotomy for
long time. Mm-hmm.
If a case gets complicated, you have to do an sternotomy, or you have an aortic dissection. I have no idea.
Yeah.
Just put in there, because we were talking about that with some other surgeons, especially young surgeons, that are actually seeking for training, what to do, and they had this concern that I have seen this concern before, but in general surgery, when everything turned laparoscopic.
Yes.
So they were saying they won't be able to do anything open.
Yeah.
What happened with this hand training? Because now you have the robot training and everything, but when you go to the field, you have to, because it's an emergency or something. Would you go you yourself, or you have someone else? Would you lose skills in there? I think it's important. It's something that people actually ask themselves.
It is an important question. And I was of the generation of general surgery trainees. So in the U.S., you have to get general surgery certified, and then you go and do cardiac subspecialty. I was of the generation that just kind of saw the beginnings of laparoscopic cholecystectomy. And when I was a second-year resident in Boston, laparoscopic cholecystectomy had just started, and not in the academic hospital, but in the community hospitals. And the question then, as you had just alluded to, was, well, how are we going to train the residents on open gallbladder surgery? And it turned out that most of the residents didn't need to be trained on open, and the majority of gallbladders could be done endoscopically. I think in cardiac surgery, that's a little bit of a hard concept to grasp at this day and age, but I think we have a lot to learn from the other subspecialties as to what the bailout maneuvers are and how to process them. In terms of your question about what would I do if I had a complication, so when we talk about me not having done a sternotomy for 7 years, that's an elective sternotomy. I did a sternotomy recently on an emergency basis, not an emergency basis, but an intraoperative conversion. Mm-hmm. And so I did that recently in the last couple months on somebody who just had bleeding that we could not identify. It turned out it was coming from the back of the heart. It was a very elderly woman. It was a mitral valve case, and we were on the right side, and there was a bleeding from the left ventricle posterior wall that I'm not 100% sure how it happened, but probably from the vent or something. And so we ended up debating. It was a very stable situation because we were on pump, the LV was decompressed, but we ended up saying, okay, well, we got to do sternotomy. And so my practice was 10 years, 10, 15 years, or 10, 12 years with my hands before I touched the first robot. And so I was comfortable, obviously, and then even after I started robotics, I was still doing sternotomy. So I think sternotomy is something that we train the residents with, but a part of me also says that there is going to be a time when maybe we catch up with general surgery and we understand. So for example, right now, interventional cardiologists, they are treating a complex set of patients, yeah. But they've never learned how to do a sternotomy, but they have us to call.
Yeah.
You know?
Before, if they had any complication, they used to call us.
Yes.
Like running, oh, there's a dissection. Right now, no, they will put another valve to close the gap in for the dissection.
Or they'll put the patient on ECMO and let them chill.
Yes.
So there's other ways to take care of it. I think
I found a way. I mean,
not having the technical capability of doing a sternotomy and bailing the patient out, I think, will be a detriment, and I don't think we should advocate for that. Yeah, no, I don't think we should be advocating for that. It seems to me that solid training with sternotomy surgery is going to have a role somewhere.
Yeah, even though we've been hearing about transplants and everything by robot, which is amazing. I mean,
yeah, it's been done a couple times. Yeah,
it's amazing.
No.
But yes, I totally agree. Do you have anything that you want to say to our audience?
Check out the ISMICS presidential series that Joel was kind enough to put together for us. We have a lot of nice robotic cases on that one. Really embrace some of the new technology that is coming around the pike in cardiac surgery, especially for the junior surgeons out there. You know, the capabilities of the new systems are going to be very, very different than what we've seen in the past, and there's going to be some good support for that. And I think it benefits only our patients.
Totally agree.
Yeah.
So thank you very much for giving us this interview and for all the knowledge that you just spread through our viewers. And thank you very much for seeing us. We'll see you in the next interview or just some videos. Please send your videos to CTSNet. They're very important and we all learn about that. Thank you.